Greetings, everyone. Welcome. This is Eric Glazer, and this is the Population Health Executive Roundtable, and we have a terrific program scheduled for you today. Our title of our session is, Are We Missing the Boat on Social Determinants of Health? Innovative Plans and Provider Success Stories Using Non-Health Data. You're about to meet 5 organizations who will be offering their insights and experiences to all of you in the hope that you can take their ideas and what's working at their organizations back to your hospital, ACO, health plan, etc. We've been running the roundtable for over 5 years now, and this is our 3rd consecutive month that we may break our record for attendance. Truly remarkable. So thank you all for showing up. I know some of you must be joining us for the first time. I ask you the favor of checking out our website, sharedpurposeconnect.com, to learn a bit more about our mission. I'm going to bypass my usual introduction so we could give that time to our roundtable experts. I just want you to know, we do produce these sessions to highlight bright spots in healthcare. I think our regulars would tell you that this is not your typical webinar. I know it feels like it, you're on Zoom, traditional, all that, but we design these so that we really focus on bringing people in front of you who are willing and able to share interesting success stories at their organizations. And I believe listening to those and determining if those bright spots are applicable at your organization and scalable is the most cost-effective way to improving healthcare in this country in our lifetime. I believe firmly in that. So I know if you've been on this call before, you've heard me talk about it, but that's what this is all about. With all that said, we are able to provide this programming thanks to all the incredible support that all of you who are attending provide us by showing up. And even though you don't have a registration fee tied to your participation, your attendance does enable us to handpick specific organizations who can both support our roundtables and also participate in them as experts. And you've heard me pontificate upon this before. We have a big echo chamber in healthcare, and we need to look outside of our lane at times when we are thinking about things like patient engagement. I prefer to call it consumer engagement. So a quick shout out to Revel Health, who is supporting today's program. They do things much differently than a traditional healthcare organization. And Sara Ratner, who I'll introduce with our other experts in a moment, she's on our panel, and she's here just to share ideas and her experiences. She's not a salesperson for Revel, but I, as the host of today's program, can unapologetically tell you a bit more about Revel Health later on in our show. I'll also like all of you to do me one solid at 12:25 East Coast time, so 5 minutes before we're going to sign off. You're going to receive yet another email from me. This is asking for your feedback. I'll be sending it to you. Our regulars know I'll be resending it to you if you don't complete it. So if you could just take the 2 to 3 minutes it takes, multiple choice for the most part, to provide us with feedback, it would be really helpful. We are planning our 2020 schedule. Your input around programming is important. Your input about how we can be better is always important. We look at those answers, each one of them, very carefully. So thank you in advance if you could take that survey again at 12:25 East Coast time. Will be coming your way. Final announcement before we start. On June 10th and 11th next year in Boston, I'm excited to announce we will be hosting an executive unconference. It's going to be our first ever in-person event, and it's going to be unlike anything you've ever attended before. The title of it's called Healthcare Unboxed. We are going to discuss innovative approaches to rebuilding programs and rethinking strategies in healthcare. And the event will be made up mostly of roundtables, just like the one you're about to watch, except you would be participating in them. We're going to have multiple roundtables, professionally moderated, for a day and a half, discussing different pre-planned topics. And the objective is to have small, focused, solution-oriented bright spots, sharing bright spots discussions and enable you to meet every single attendee at the meeting. So it's going to be small and intimate. It is for only health plans and provider organizations, and you must be in a senior level position. So if you want to apply to attend, you could go over to the Shared Purpose Connect website, and in fact, or fill out the survey, and we'll be able to follow up with you. But there's an application that we're going to look at. If you do get approved, it'll only be $5.95 for your organization to pay up for you guys to attend. If you do not represent a plan or provider, we are going to work with a few select sponsors to participate in this meeting and even help plan some of it if you want. So you could simply apply on the app, on the website, or email me directly or message me on LinkedIn if you wanted to chat about it in more detail. So excited to meet many of you June 10th and 11th in Boston. You can mark your calendar. All right. We are not going to formally introduce our panelists from a bio perspective. You all received an email with their bios. If you have not, our producer Sherry Keels is going to post a link to their bios within the chat window. This will give you a sense of the value you are about to receive over the next 55 minutes now. So I want to jump into our questions right now. And for that, I'm going to start off and bring in Lisa Holden. She's the Vice President of Accountable Care at iCare, which is a health plan that is part of Independence Care Health Plan. You can learn, again, more about them in the bio sheet. Lisa, let's bring you on and let's just set the stage and tell everyone, or let's talk about what are some of the most common misunderstandings around social determinants of health.
Well, that's a really wonderful question, Eric. I've been in healthcare for 36 years, and I think one of the misunderstandings is that this is a new phenomenon, that we've just discovered that there's this thing called social determinants of health. At this point, at least over my career, this is generational. When people are living in poverty, they are faced with these issues throughout their life and the next generations as well. So I really hope that all the attention that social determinants of health are getting right now doesn't fade away when the next shiny object comes out.
Okay, I want to get right into the meat of the topic and talk about how organizations are integrating SDoH to make an impact with engagement. So Kenyatta Hicks, he is the social services manager at Blue Cross Blue Shield of California. And Kenyatta, I know you're on audio only, so you won't be able to see Kenyatta. Could you address that? Like, how is Blue Shield of California leveraging SDoH?
Hi, sure. So I've been at Blue Shield Promise Health Plan for about 3 years, working in the social service department, primarily at our Blue Shield California's only 2 Medi-Cal clinics in Southern California. Our focus at Blue Shield California is healthcare that is worthy of our friends and family. So throughout the past year, at our clinics, we focused on a shift from the traditional healthcare model to a more person-centric model, which embraces whole person care and social needs. Whole person care to us means helping our patients with all of their needs when they walk through the door, not just their medical needs. You know, there's so much data and research out there now that show the direct correlation between social determinants and medical outcomes, especially with the Medi-Cal and Medicaid population that we serve, who historically present to have less access to basic needs and resources and more challenges to staying healthy. So it just made sense for us to address these social needs. So we began our first phase of implementing this as part of the normal patient routine visit. We would give them routine social determinants of health assessments. So these were scheduled and standardized screenings. We screened for depression, we screened for childhood abuse and neglect, we screened for basic needs, and this allowed our providers to consistently identify social needs and act quickly. So the screenings have kind of given us the chance to engage patients on a more personal level. The PCPs and the MDs are talking to patients about things that weren't really talked about before, like trauma, family dynamics and dysfunction, financial strain, access to things like transportation, food, recreation. All these things we know impact health. You know, and it wasn't just good enough for us to ask these tough questions. We also wanted to be able to jump in and help. You know, they're trusting us enough to answer these questions. We wanted to give them resources and support. So the next thing we did was we deployed community health advocates or community health workers into our clinics and out in the community. So the community health advocates are sort of like social needs and community resource experts who would build rapport, engage, develop personalized care plans to address these social needs. They not only engage the patients on site at the clinic, but they'd also conduct home visits and meet patients out in the community, really meeting them where they're at. The last thing we did was we incorporated our community health advocates into our clinic care teams. Our care teams were comprised of a medical doctor and medical assistant and sometimes a nurse case manager. These care teams would meet daily to discuss patients and to coordinate care. So our community health advocates are kind of like the social work eyes of the care team, so to speak, giving the social needs a voice in the patient plan of care. And over the past year, our data have revealed, a dramatic reduction of ER visits and hospital admissions since we transitioned to this model of whole person care. And we can attribute a key factor in us becoming more cost efficient and seeing improved health outcomes to the high touch care we now provide and our commitment to addressing these social determinants. So that's pretty much how we integrated whole person care and social determinants into our clinic.
That's great. I'm going to summarize that, Kenyatta, make sure I get this right, because I want to make sure that folks are taking notes, they're capturing all this. Whole person care is the focus. It all starts with the questionnaire and making sure that gets implemented at the clinic. And as far as implementation, the community health advocates, aka the community health workers, are the key to delivering and supporting on those determinants that you identify in the questionnaire. And finally, one of the keys to success, and we'll dive into process a little bit more later, is the CHAs being part of the care team with the PAs, the RNs, and the physicians.
Correct. You said it right. Yeah.
Perfect. Great. All right. I want to get a different perspective now from the provider perspective. And by the way, folks, there is a Q&A module at the bottom of your screen. We are jam-packed today. I will do the very best I can for questions that come in that are on point with where we're going in the dialogue, and I'll try to integrate them in. I'd prefer you not use chat. I will look at chat too, but the Q&A module is a little bit easier way for us to manage all the questions that will come in. And also, I am not looking away from you when I'm looking to the right, but I have two screens and paper here everywhere, and I'm trying to manage the questions coming in, the questions I need to ask. So just know I am paying attention, but when my eyes go over there, I'm just looking at the screen with other information for me. All right. Dan Behrens, he is the manager of accountable care communities at Allina Health. Dan, how are you guys leveraging these non-human or non-clinical data points?
Yeah, great question. So similar to Kenyatta, Allina's approach is really focused on that whole person care model. And a big part of that is focusing on the social determinants of health. And so Allina actually has over 75 sites that are screening for social determinants of health through the Accountable Health Communities grant that we were awarded from CMS. So we're screening Medicare and Medicaid patients that are coming into our clinics, as well as a couple emergency rooms, mother-baby centers in our system. And so it's really a clinical focus here. And as Kenyatta mentioned, this is, it takes a village. You have your care teams, you have your front desk staff providing these screenings, you have your medical assistants that are entering this into our EMR, which is feeding into our NowPow partner technology tool. So we're using NowPow to give resource lists to patients that are screening with needs and helping to support them and connecting to the resources in the community. But really, yeah, Allina's been granted this 5-year grant. So we do have a bit more of a guardrail around what we can and can't do. The questions we can ask. Right now we're screening for food insecurity, housing instability, utilities, transportation, and also interpersonal violence. And for those that have also had high utilization in the emergency rooms, because it's a research study, they're being filtered into an intervention group where they're getting support. And those that are not high risk or have not utilized the emergency room 2 times in a year are actually getting a resource summary from NowPow, but not getting that personal touch.
Okay, great. And so, and can you delineate between folks that you sort of have what I would say moderate interaction, engagement, and action versus those that are more severe?
Yeah, so based on the need and based on the relationship and interest from the patients that are coming in, there's varying levels of touch. So some are working with patients for 10, 11 months with calls every month, calls every couple weeks based on the needs. Others, it's maybe that warm handoff is made to a community benefit organization and it's a 1 or 2 touch thing before that patient feels comfortable. That goal of maybe it's food insecurity. They feel like they have what they need now to get the food for their family. So it really depends on the patient's needs as to what level of touch they're receiving, and we are kind of tiering that based on patient demand.
And is that, I know when we talked about it a couple of days in preparation for today, you mentioned that a certain percentage of folks, I think roughly 25%, get assigned a navigator. Is that what you were just alluding to, or is that separate? Is that the most complex?
Yeah, so it's broken down as a research study into intervention and control. And so to be involved in that randomization, you have to have that high risk criteria, which is the 2 or more ED visits. And that that has been about a quarter of patients that are doing the screening, which is actually about 1,500 patients a week in our system are completing this. So we're getting a lot of data from it. Are high risk, and of those, some are going to be going to intervention, some are going to be going to that control where they're just receiving a referral summary.
Okay, great. Hey, Kenyatta, come off mute. I'm coming back to you with some follow-ups, all right? There's been a bunch of really good questions. I want to make sure people have a take on this. Is there are the community health workers, the CHAs, are they employed by you guys, or are they contracted through, or are they part of the provider organization?
Yeah, they're part of our social service department at Blue Shield Promise Health Plan, so they're employees.
Okay, and what is the ratio of CHAs to the care team? Do you have a sense of that?
We have about 6 care teams amongst our 2 clinics in Southern California, and there's one community health advocate assigned to each care team. So they're working really closely together throughout the year, getting to know each other, getting to know the patients, getting to know the patient needs. And we think just building that relationship and knowing who the person is when they walk through the door and what all their needs are is whole person care, and how we can best coordinate care, for our membership.
Got it. And do you have any kind of technology solutions behind the scenes helping you collect the data, or is this all in the office, clipboard, pen and paper, old school?
No, we're pretty much fully digital. We have an EMR system and a charting system which tracks referrals. It tracks what people are being referred for, and also tracks our intervention. So we're pretty automated and research minded. I mean, data is pushing everything now. So, you can help people, but they want to know, the numbers. So we are automated and digital. So yes.
Okay. Great. Thank you for that. Also, I know this was asked. This session is being recorded, so we will send you a link to the copy of the recording within probably 24 or 36 hours after we're done here today. All right. I'm going to move on with the same question, but I want to bring in Susan Mani. Oh God, did I get that right? Susan Mani?
You're good, Mani.
Susan is the Vice President of Clinical Transformation and Ambulatory Quality at LifeBridge Health. She is a physician by training, and she coached me on her last name just yesterday, and I've already screwed it up. So go ahead, Susan. How are you guys leveraging SDoH?
Sure. Thank you, Eric. We're doing much of what I'm hearing already from folks here on the webinar, and what we really did was spend a great deal of time engaging our physicians and our other clinical partners into utilizing the social determinants of health as part of their assessment. So I heard mentioned earlier in the webinar about really thinking about how to maximize clinical outcomes. And so our physicians just didn't have a language to use or a tool to use to really think about how do they maximize some of the clinical gaps in care. They recognized that they weren't always able to get what they needed for their patients, and the SDoH tool was a wonderful way to be able to get that for them. So based upon that, we've actually incorporated an SDoH tool to be used as an assessment in our practices, in our ambulatory practices. This allows our teams then to access our care management teams for our high-risk and our rising-risk patients, so that many of our practices don't have those kind of resources embedded or built in. And then in our ED, as well as our hospitals, our care management teams are embedded directly as part of the ED provider teams and the hospitalist teams. So they all do social determinants of health as part of their initial assessment. And then what we do is we link it to about 500 or 600 community-based organizations that we have partnered with to really make sure that we recognize care as local. So for many of our patients, they really want to be within their very local community to access some of these resources to address the social determinants of health. So we spend a lot of time as a healthcare organization building those relationships, building an inventory, and really making sure our providers and our patients can actually access these resources. And that's made a significant difference in our readmission rate and our avoidable utilization.
Wow. Okay, it's great. Let's shift a little bit to strategy here. I'm going to bring in Sara Ratner. She leads government programs as the executive advisor for Revel Health in this domain. Sara, how can health plans and/or integrated delivery systems be a little bit more strategic in thinking about SDoH at a very high level?
Sure. So, from my experience, there are a couple of populations that have typically not been included. So health plans, from my perspective, need to make sure that all of the populations that could be impacted by social determinants are included. And I'll give you a couple of examples. First is the incarcerated. To give you a sense for the impact of incarceration, there are two components that I would put out there. First is the family, and then the second is those that are actually incarcerated. And we know that incarceration for families creates these lifelong social determinant life cycles, and it can impact, it's multi-generational and intergenerational. Kids whose parents have been incarcerated have a 60% rate of reporting mental health issues. And we also know that the suspension and incarceration rate for kids of those who are incarcerated is huge. Relative to those who are incarcerated, we all know the substance and mental health issues that they struggle with, the lack of earnings post incarceration. And most shockingly to me is that these individuals who come out with no health care, no follow-up, no medication prescriptions, they're 12 times more likely to die within 2 weeks of release. So there's a tremendous need to focus on this population. The second of the three where I think plans need to focus is the rural community. Twice as many people live in poverty rurally. Healthcare coverage is very, very low. On average, there's about 39 physicians for every 100,000 people rurally. And we also know there's tremendous transportation access issues with a very low per capita income. And so when you add these all together with high deductibles, it becomes untenable to get healthcare with all these other compounding factors. And the last area that I would put out for this audience to consider is the employed, actually. And we've been doing a lot of work in this area, because if an individual is at or below the federal poverty level, chances are they're probably underinsured if they're not on Medicaid. And that is really hitting a tipping point in our society right now, where premiums for employer-sponsored coverage have increased over the last 10 years by 55%, which is twice as fast as workers' earnings. And this creates an unaffordability issue where people are not getting the care that they need. Of the 150 million Americans that have employer-sponsored coverage, 24% report being underinsured. And we also know that half of all credit debt is medical related. So the underinsured are actually in a more precarious situation in some respects than the uninsured who are on Medicaid, because we know that many of them have to use their savings. We know that 38% have taken on credit card debt because of unaffordability issues, and a substantial amount also took out a second mortgage. And if we as an industry are planning for how these people are transitioning into other types of care, such as Medicaid or Medicare, their behavior and pattern of not utilizing healthcare because of experiences with not being able to afford it, and then going into more robust coverage, which can be Medicaid and Medicare, we have a crisis that these folks are not going to utilize care. So there's a teachable moment to enable people to actually start getting the care that they need with this history of not being able to utilize it.
Great. Susan, could you bring in because that's a pretty sophisticated thought process. I don't know if all the health plan executives are actually thinking that way. I hope they are. What about sort of at a provider organization? What's the perspective there from a strategy standpoint?
So LifeBridge has really incorporated the way that we think about population health, that there is a social determinants of health strategy as part of our population health strategy. So that has been a significant shift in the way that we have done things. So our mission has always been to serve our communities as part of LifeBridge, but what we've really done now is make it a robust part of our strategic planning. So as we work with specific community organizations, health agencies, as well as our state regulations, and even the way that we think about our practices, it really starts to now delve into, do we build, do we partner, do we buy? So part of this is, many of this has been, how do we get strategic partnerships to really make sure we're addressing our social determinants of health, and how do we work with other health organizations, because this really can't be done alone. To give you a very concrete example, we obviously had figured out for a number of our readmissions, we saw that about 20% of our readmissions for certain clinical DRGs were really driven by homelessness or just housing insecurity. And for that reason, we've actually partnered with 2 or 3 different health systems, as well as healthcare for the homeless. And we are putting some of our dollars together to actually make sure that we have, we all together pay for affordable housing units. And we really make sure that our clinical programs then are built into these programs so that our highest needs patients really take top priority. And that's something that we really hadn't seen before. This is a very strategic decision. It was about outlay of funds. These are operating costs that we are, making sure that we are putting in, but for all the right reasons. We also are making sure that our return on investments, when we think about population health programs, are also done in a very strategic way. It's just as if you thought about any other service line. What are you really buying in terms of value in a particular service line? We're thinking about population health in that same way. And so our social determinants of health have to be a part of that equation. It's part of the foundation. It's a pillar now of population health, which I think is something for many health systems that's a radical change then from years ago.
Right. And if those of you who don't know LifeBridge Health, they're in the greater Baltimore area, so pretty urban, right, population. Correct. From that perspective. I want to shift from strategy back to execution. But before I do that, I just want to give another shout out to our friends at Revel Health and thank them for supporting today's event. I just want to let you guys all know why they're a perfect fit for today's topic. They do work on behalf of plans and ACOs to take what I think is a very sophisticated approach to focusing on an individual's needs. So if you've ever been sort of exposed to the agencies on Madison Avenue, the ones that represent the big consumer brands like Toyota and Apple and Coke, they take a much more sophisticated approach than most of us do in healthcare in identifying consumers and then understanding the consumer's values well enough to influence behavior change. So we in healthcare, we haven't been that great or sophisticated in that approach to marketing and engagement to the patients, especially who are at the highest risk of costing us more money until I think now. So I want you to check out Revel, that's REVEL-health.com. I believe they're one of the new bright spots in healthcare. Thrilled to have them as part of the Population Health Executive Round Series. So thank you, Revel, for being here. Let's now get into execution. And I want to talk about the one most critical success factor in successfully executing an engagement program. Let's bring in Dan Behrens at Allina Health to do that. Dan?
Yeah, so kind of referencing earlier, the scale at which we're rolling this out. With the grant, we were able to push this out at, like I said, over 75 sites. So tons of people involved, tons of people that need to buy in for this to work. And I think it really starts with support and commitment to prioritization of this as an organization. And so you'll hear our CEO speak about this work more than almost anything else that's happening at Allina. And I think that really shows in terms of where the system is focusing its priorities, its strategic initiatives moving forward. They're really committing to this, adding it to scorecards for clinics, looking at it, making it business as usual so that after this grant is up, we have an approach to screening and supporting social determinants of health as well. And so really, I think it's that focus at the top and commitment at the top, but also really utilizing the intrinsic motivation that a lot of people in healthcare have in helping others. I mean, 80% of health is determined outside of what we traditionally call healthcare, and that's your social determinants. And so how can we support our patients in a space that really is pretty untapped in terms of how health systems specifically are focused on this. So I think Allina's, really using that whole person care focus and using that commitment to motivate folks that this is good work and this is really helping our patients. And obviously for people to buy in, they have to see it working. And so that's a big part of our push for getting screenings out. The more screenings you get out, the more people that you see have needs, the more likely it is that you have that personal success story that you can share with your peers, with, that you can carry with you as you're doing this additional step in your clinical processes. So I think that's a big part of it. And it's sharing those stories as an organization, talking to people that this has worked for. And if somebody hasn't had a personal story, trying to share what we've learned as an organization of how much of an impact this is actually having on people's lives.
Dan, and so I know we said most, and you've mentioned a couple of things, intrinsic kind of mission from the bottom up, the top down buy-in. But when we spoke earlier, you had mentioned something about workflow and making sure that things fit within sort of the existing clinical resources. Could you expand upon that for the group and just let everyone hear that for the first time?
Yeah, as we rolled this out, the strategy, just given the scale, was that we needed to use existing resources. So building it into clinical flows involving the front desk, medical assistants, the kind of care management RN type of a role that we have in our clinics to really build this out. And then using process measures and data. So we have a really robust data reporting system. We're sending out weekly updates to the sites that are screening and navigating patients to let them know how they're doing on the work, to be able to connect to peers that maybe have had more success in the screening realm, or others that have had really high success in getting outcomes for patients they're navigating. So being transparent with that data and really using data to inspire, and then also to translate what that percentage point really means in terms of lives. 22,000 people I expressed needs to Allina Health in the first year of this screening. That's a lot of lives that we're touching with this work. And so really trying to connect it down to that personal level for the folks that are involved in the workflow to really see the impact.
That's great. What about, and you're in the Minneapolis area, right? Just to give people perspective of the market you're in. I want to bring in Lisa Holden. She's in the Milwaukee marketplace at iCare. What's the one most critical factor from your perspective, Lisa, if different from anything we've heard so far?
I think it is that we design our care teams to reflect our population that we're serving. We too have community health workers. We assign them to neighborhoods so that they become true experts within that neighborhood. They also have to live there. And I think that's what makes our model so unique, is that if you look at our staff, we're very diverse, very, very committed. We don't stop at let's just get the work done and move on. We really dig deep to find out what these what all the factors are that are impacting our members, and our staff can relate to it. And I think that's extremely important.
That's great. Kenyatta, what about for your program and your pilot? What's the one most critical variable for success?
So as Dan touched upon, operational processes are really key to implementing something like this. And also, as Lisa touched on, our advocates are also, members of the community. So they're invested and they're interested in helping the people where they live. Other than PCP buy-in and leadership push, I would say a key to engagement and building a program like this is the relationship building. Okay, you need to put the right people in place to execute all of this. And our community health advocates are kind of driving this movement. Once a patient truly believes that you care and understand who they are and what they go through on a day-to-day basis, they kind of trust you and engage in a more buy-in of the care plan that you create with them. So we're not only providing resources, but we're also providing the emotional support by listening to the patient, meeting them where they're at, involving them in the joint decision-making process. People many times remember what you did for them, but they don't forget how you made them feel, right? So relationship building is a key driver to engaging in compliance. In the past, we've seen that our patients had kind of more trust in going to the ER than they did coming to our clinics to get treated. So we stepped our game up in this area. Our patient satisfaction surveys show that people are having a better experience coming here into the clinic and seem to be healthier as well. So I feel that relationship building is a real key factor in rolling out a program like this.
Kenyatta, do you know the average caseload for your CHAs?
They average between 20 to 30 members, and it fluctuates. We kind of don't like to hold on to cases too long. We kind of tend to screen them, assess them, find out what their needs are, get in and help them quickly, and send them back to the PCP in a better place than when we got them and move on to the next member. So the caseloads carry about 25 to 30 members at a time.
Got it. Now, I know we're getting a lot of questions coming in, and I'm looking at the time, I'm looking at the questions we have planned. For those of you who are asking questions related to funding, showing impact, ROI related questions, we're going to get there. We're going to get there the last 15 minutes. So just stay patient. We will. It's part of the plan here. All right. So great. That was great, Kenyatta. What about Susan? What about for you? What's anything different? Like, what's the one thing that is?
Just to add, because I agree with what everyone has said are critical elements, I would say data analytics platforms are critical to success. So if we're really going to treat social determinants of health as a fundamental pillar to get high quality outcomes, then you really have to give it the same amount of substance and rigor that we would do with any one of the other pillars. So when we think about business intelligence, when we think about any other scaling opportunity, so we've invested a lot of time and resources and funding, as we talk about that later down the line, and really around our data and analytics around this. Because what we've often found is that there was not a lot of robustness around this as we would do for some of our service lines if we thought about it from an RVU standpoint, for example. What are the kind of resources that you need? How are you actually going to measure ROI? How do you know that this is giving you the sort of outcomes that you believe are happening to an organization? How do you help prioritize? So I would say that needs to be a part of the planning for any organization as they're thinking about it. You really do need to think about how you're going to measure, how you are going to be able to take this information and communicate it out to your various groups.
We're going to shift back to strategy and then shift over to ROI. So I want to bring in Sara again. I want to talk about strategically how our plans, or how should plans and ACOs be thinking about their policies and their overall strategy in anticipation of political changes.
Sure. So there are a number of different changes that have transpired over the last couple of years that have impacted social determinants of health and in a positive way. There are current and potential legislative and regulatory changes that will impact our industry that are actually quite interesting. And I'll give one example, which is a new community investment tool, which was established by Congress as part of the Tax Cuts and Jobs Act of 2017. And this did several things, which I think is one of the most interesting kind of combinations of social determinants and the investment community today. So it created this new investment vehicle for undercapitalized communities, which are known as opportunity zones. And this encourages long-term investments in these low-income and rural communities nationwide, and essentially provides a tax incentives for investors to reinvest their unrealized capital into dedicated opportunity funds. And if these individuals hold those investments for 10 years, investors pay no taxes on any capital gains from opportunity zone investments. Right now, there's about 8,700 individual census tracts across all 50 states that are designated opportunity zones. And this essentially governors select the tracts that on the whole demonstrate the distress. And the result of this has been a map of both need and opportunity across, which is some of the most exciting economic and community development experiments in at least a generation. And what I'm seeing is that there are these strategic partnerships between the opportunity zone funds and payers and providers to leverage these dollars to create very interesting, innovative, strategic investments in housing, in transportation, in different things. And it's a way to essentially front load some of these investments that a health plan or provider would have to pay for, and use an investment vehicle to help fund that need. And these areas are very, very distressed from a healthcare perspective, as everybody on this call knows. So this is a really interesting, innovative way that we're seeing players start to invest opportunistically across all different industries to help deal with social determinants of health.
That's great. That was really interesting. We'll try to circle back to that question if you guys have follow-ups towards the end here. I'll keep an eye on the Q&A module. Let's talk about ROI. Lisa, how are you guys showing a financial ROI in any of these interventions that are prompted by social determinants?
You know, Eric, we just created a committee a few months back, and we said, look, let's look at all these social determinant intervention programs we have and find out if we're actually getting any ROI. And our financial data analytics team went to work, and they presented the results originally, said, here's what we found. And we said, well, you need a control group. So they went back. Then they came forward again, and we were astounded that every program we have implemented has a significant return on investment. And this is taken into account all costs for the program. We're still seeing really significant savings, and it's very exciting.
Could you define significant, or at least tangibilize it a bit for us?
Yeah, absolutely. We've been talking a lot today about community health workers. We've been able to show that annually they have been able to save $31,000. That doesn't sound like a lot, but I would have thought that the cost of having those positions would lead to no savings. Well, they do bring savings. We have a follow-to-home readmission prevention program that has netted $1 million in savings by following people for 90 days after discharge, not just for 30. Program by program, offering meals post-discharge, we've seen $800,000 in savings. Every single thing we do leads to savings. And it's very exciting, so we can scale up and go into those rural communities that were talked about a little while ago.
And when you mentioned the community health worker $31,000 savings, that's a net after the resource has been paid for?
Absolutely.
Okay, so that gives people some confidence here that if you put some chips on the table, you'll get more coming back. Susan, and I'll have some follow-ups for you because there's a bunch of questions that came from the audience for you too, but how are you guys looking at ROI?
Sure. So Maryland, I don't know if the group is aware, we are under what's called a global budget system, and as part of the waiver program, we actually have very specific population health metrics that we have to achieve. And as part of our global budget, our rates are set by some of the success that we have about really preventing all payer, all cause readmissions, as well as what we call potentially avoidable utilization. So when we take a look at our ROI, we can actually put a defined cost for each of our facilities about what each single readmission costs us, what every single potentially avoidable admission costs us. And then there are other things that we do that traditionally we may not be thinking of. If we are doing care coordination and addressing social determinants of health appropriately and well, then what we're often finding is that we get a pickup in our volume in our PCP offices, for example. So we are getting revenue from a different kind of way that we are not usually thinking about. So we have taken all of those into account when we think about ROI. For example, we did a significant care management transformation in our emergency department that obviously came with a cost. We decided to move to a 24/7 model that really made sure that we had community health workers and social workers embedded, which was a different way of thinking about our care management program. And what we found is that within 3 months of the program, we had break even, and within 6 months, we actually were able to show an ROI for that program. That program still continues, but within 6 months, we had complete coverage of all of our costs for what would otherwise be considered a rather expensive program if we didn't think about it this way. So I think it's a way of utilizing ROI in a very different way, thinking about how are you also maximizing, for example, if you're in value-based contracts, many health systems may already be taking some downside risk, or even if you're not, you still have the potential for gaining upside, potential for your providers or for your ACO. All of those dollars go into what we call an opportunity bucket for us. So if we can achieve maximal effects there, that's part of our ROI calculation. Eric, I couldn't hear you.
Is this how you, is this ROI approach and everything you just stated, is that how you are able to fund, let's say, the housing initiative that you mentioned earlier?
Yes, so many of these are coming from, this ROI is the way we actually look at every single one of our programs. And then what we have done is used a platform called Socially Determined, for example, to give us an idea of where opportunities exist around social determinants. With that, we're actually able to link that to our clinical outcomes to really say, here are the gaps that we have that we feel are related to social determinants, and there's a cost with that. And through that cost, we think a particular program based upon our analysis, and we work very closely with our financial team to help us determine this. These are the kind of programs we often piloted. For example, I'll give you a concrete example. We have about $800 million in total costs for our health system around our end-stage renal disease patients. So when we broke that down, we were finding a number of our dialysis patients were driving what we consider inappropriate costs. And we were able to get a group together that consists of our clinical teams as well as our social workers to address clinical gaps in care as well as the social determinants of health. We found a 60 to 70% reduction in cost of our highest cost patients by doing this. And then determining the ROI with our financial team, we're actually now able to scale that up and provide additional resources and navigation to create a panel of patients for about 250 to 300 patients that will continue to help reduce those costs, but we did that based on our ROI analysis from that pilot.
And as it relates to taking the impact that you are able to make and invest it in other initiatives, do you have a central location to manage all your resources and then enable a sort of a resource allocation approach? Is it publicly available through the organization, or is it only available to the medical community? You know, how does the sort of, who manages that list of resources?
So we do that through population health. So our population health department, where our analytics live, as well as our programming and our process improvement, all lives under one house. We really manage that inventory. That doesn't mean we own the scope of all of those programs. For example, some of our service lines do some of these programs. Many different parts of our organization do it, but we act as that sort of central repository. And we really try to make sure we are collaborating and partnering with all different parts of our organization to do this. And I will tell you, it's an ongoing journey. So we've been doing this now for about 2 years, and we continue to find little pockets of brilliance, as we call them, in different parts of the organization that we didn't realize. But then we bring them into the fold so that everyone can make use of the same kind of standard mechanisms that we're thinking about: programmatic improvement, process outcomes, as well as ROI.
Okay. Great. And I'm gonna throw another question out. I think I'll throw it at, I know, Lisa, this is a little bit unplanned, or Kenyatta, either of you could jump in on this, or Susan. It looks like it's a CHW question. Are you drawing correlations to the CHW costs tied to specific reductions in the disease cost, or is it utilization costs? And I think, Lisa, you'd already mentioned it's readmissions that you were driving at. Is there anything that you're doing around reduction in disease? And Kenyatta, same question for you. And then the follow-up is there an EMR or analytics platform that you're using to support this?
So I can start. We are not tying it yet to disease states. We are looking at the overall inpatient costs and then total costs. That's how we evaluate ROI currently for the community health workers. We do have an EMR. We're struggling to get consistent documentation. So I think the ROI will actually increase once we have a more systematic way of capturing everything those CHWs are doing.
Yeah, Blue Shield, we're really concentrating on inpatient costs and ER admits. We do have an EMR set up, and we're working on data collection now to kind of evaluate exactly what interventions are associated with cost reduction.
I would also just add that I think not necessarily ROI, but engagement related. When you start seeing A1C decreasing because you can get healthy food on the table, or you can attend your diabetic checkup appointments, you start getting that buy-in from providers as well.
Sara, how do you look at, you get to work with multiple organizations, how are they looking at ROI for these significant investments?
Well, I think the first thing is, how do you sell or convince the organization that this needs to be a critical path? And these days, that's not terribly difficult, but you need to pre-fund them and take a bet on them. And a lot of that is driven by who the executive leader is sponsoring these programs, if it's the CFO or if it's the CEO. And then, really it's honing in on what is the data and what are you trying to influence, and not biting off everything. So the data to identify the gaps and to be able to demonstrate the pre and post investment cost is absolutely critical. And the data you can use a number of different things, from demographic to STARS, HEDIS. Surveys are a great tool to be able to understand where the gaps are. And then, figuring out what interventions are you going to apply, and be very specific about what you're trying to drive. And ultimately, what data will demonstrate the value. And this can be very direct type of data, such as, A1C improvement to overall CAP scores and mortality rate. But ultimately, it will get you to a ROI that, if everybody's on the same page, you can measure it consistently.
Okay, I'm going to ask a follow-up, and Sara, maybe outside of your sweet spot, in which case I'll ask the team of experts to jump in here. How are organizations approaching impact analysis on a specific intervention? So a specific SDoH intervention, whether it be a Lyft Uber program, whether it be a housing program, a CHA program for certain high-risk individuals, how is that being measured as success or failure? Because that's not necessarily indicative of your entire SDoH strategy, but more on a program-specific level.
Yeah, I mean, take for example, flu shot, which is really, really basic and easy to understand how you're measuring it. You have to understand how many people are getting the flu shots, what the cost is to actually get the flu shot. So there's going to be cost associated with it, but we all know that is a substantial, there's a cost if people get flu, if they do get the flu. So being able to look at what your pre-investment cost is with the flu, then post-investment cost of savings on not having to address the flu. And then ultimately that leads you to your savings and ROI. So it's not terribly difficult, but there's a lot of components that go into how are you going to measure this?
Does anyone else want to jump in on that?
Yeah, Eric, this is Lisa. I also am curious how others are managing the fact that, our members are not receiving one intervention at any given time. They're receiving multiple. And it's very difficult to really nail down what was that secret sauce, what exactly, and if anyone knows how to do that yet, I'd love to learn, because it's very complicated to tease out all the interventions that we're offering and which one has the highest impact.
I'm going to shift a little bit, Dan. There's been a question hanging out there for you, and it's sort of kind of a nice transition here. You mentioned earlier more screenings result in more success stories. Do these stories, are they passed on from clinician to clinician or peer to peer, or how do you sort of package the message and get these success stories to go viral within your organization?
Yeah, it's a little bit of both. It's partnering with our communications department. It's a little bit word of mouth. You also see a significant amount of investment in producing things that people want to see. So we've actually made videos too with patients that have had the success stories that we're recording, the navigator, the CHW that's performing the navigation with the patient, what their perspective of the experience was, how it made them feel to be asked these questions in a clinical setting. So we're doing it a variety of ways through, the CEO email once a month, we'll be referencing it, or you'll get the videos that are circulating. You'll get the performance transparency, on a weekly basis as a clinic. So a variety of ways, but I think, everyone takes it in a different way. So I'd say, do you like the video? Do you like the visual? Do you like the data? So we're trying to provide a wide variety of things there. And I also think one thing that hasn't been mentioned much on this webinar yet is the the CBOs involved, the community organizations, they're very interested in seeing data. They're very interested in seeing, how many people are getting referred to them by our organization or by a certain clinic. They're trying to build those relationships too. So I think internally, there's a lot of communication. Also externally, there's a very large appetite from, I would say, payers, also these community organizations who are looking to make this work financially for them in the future too. How can we partner together with them, and how can we share our data of where needs are? Is the rural community that Sarah was referring to earlier, is there not a shelter within 40 miles for women? That's an issue, right? How can we use that to drive policy, to drive, strategic investment, and to really focus on the needs of the communities?
Well, one other thing I would add is, being in the same town as Allina, and the impact that a lot of the investments have made, there's a virality that's created where those investments and ROI are not as difficult because it just becomes implicit on the, direct and indirect costs that it's going to save. So, being able to put out data, videos, putting a face with a name is critical. So the organization just becomes enmeshed with the need to be able to drive improvement in the space. Eric, you're on mute.
You promised us one time today.
Yeah, I was pressing my button to unmute it. Sorry. So first of all, quick reminder, everyone, surveys probably showing up in your inbox any minute now. Take the time, 2 or 3 minutes. We really appreciate it to provide us feedback and guidance for 2020. Dan, we were talking about CBOs. Are you in charge of CBOs or partnerships? Do you guys have a team in charge? Like how is Allina approaching CBO partnerships?
Yeah, so the infrastructure for the Accountable Health Communities program at Allina is all within the Community Benefit Department. So we have our regional leads and supports that are already connected to the forums that are happening, to making these connections with large organizations, other health systems. I mean, there's plenty of people that they're working with already. And so we are leveraging those relationships to really continue to build out relationships further with community organizations. But just inherent in the department that I'm employed under, there's a lot of relationship building and work that goes into maintaining that connection between the health system and the community organizations.
Sara, a couple minutes left. I'd love to talk a little bit about, very quickly, about other industries that you're looking at regarding sort of social determinants like data, and who maybe folks in the audience could benchmark off and look into as far as doing a great job leveraging these things to drive behavior change.
Yeah, so you mentioned early on that there's a lot of different organizations that do things very, very well that are outside of the system. And it really, what we've noticed is it's this one-to-one dynamic that is created by a lot of these non-healthcare organizations where they have, they've gone against the one-size-fits-all approach to be very precise in their personalization. So having people, when they self-report on social determinant of health factors through screenings, the messaging that goes from there is highly specific to that person. So you know that the engagement that you're asking of them is going to be impactful and they're actually going to do it. And then really the communication, understanding who your audience is and drafting very specific communication to the individual around language preferences, situational awareness, environmental, those are all critical. But a couple of examples I would give where I see a lot of interesting, I guess, tips being taken is Amazon, where there's consistent communication for purchases. Starbucks, there's location-based engagement. Apple, where you meet the consumer where they're at. Facebook has behavioral triggered email. Spotify is group engagement. And then Netflix is personalized and dynamic communication. So if we can bring those in, we're going to do a lot better at getting the patient engaged.
Thank you for that. That's great. I want to also just quick shout out to everyone at Revel again. Thank you. In the spirit of networking, and those who know me know I'm basically a networker. That's what I do for a living. If you're interested in just learning more about how to not think about your population as one broad brush stroke and looking at individuals the way Revel does, reach out to them. You don't need to be a client to network with them and to talk to them. And if you want a direct contact at a senior level, email me, message me on LinkedIn, whatever, and I'll make sure I connect you with the right people there. They're incredibly smart and have all kinds of experiences, as you hear firsthand here with Sara. Also, I want to thank the rest of our panel so much for taking the time, not only just today, but in preparing for all of this. Thank you all for showing up. Please fill out the survey. It's in your inbox for sure right now, so I appreciate it. We are not going to do a roundtable in December with the holidays. I also want to catch up on the Bright Spots in Healthcare podcast. Those of you who subscribed, if you haven't, subscribe, where I go an hour in depth in detail around bright spots with one individual. It's on Apple, Google Play, Spotify, everything else. So we'll be on live next on January 16th. That's a Thursday. It's not the fourth Thursday, but I have to adjust the schedule a bit for different travel conflicts. So January 16th, 2020, we'll be back here, 11:30 East Coast time for our next session. Thank you all, the panel again. Great job today. And thank you all for listening. This will mark the end of our show. If we didn't get to your questions, I really apologize. Reach out to me. We'll try to get you answers, maybe asynchronously. Thank you all. Have a great rest of your day. Great job.